You ready?
Good to go.
All right, so we've been sort of following this curriculum and fundamentals, and I guess last week we really did talk we talked about respiratory failure and mechanical ventilation. And we were talking informally that really to get to know mechanical ventilation, you gotta do it even when you're in the ICU, really. Or hang out with the respiratory therapist. So we're not going to get further into depth about mechanical ventilation.
What are you doing?
So what I thought we could do is talk about hemodynamic monitoring and oxygen delivery, and just talk about things like Swan-Ganses and flow tracks and things that you might see in an ICU. Talk about the rationale in changing certain types of medications to improve oxygen delivery. Is that valuable? Is it not valuable? And do it in an informal way. But I guess the first thing we'll talk about is hemodynamic monitoring. And who do you do that in? What are the positives and negatives in doing that? And does it really affect outcomes? And I think that's still somewhat debatable. I don't think it's, I think if you know what you're doing, it probably is helpful. So when I first got out of training, and I first got boarded in critical care, shortly after that, one of the societies sent out a sheet of paper with Swan-Ganz tracings. And they had all these people that were critically care certified figure out what the numbers were and send back answers. And it was a very small percentage of people that could actually tell them what the numbers were on those tracings. Because the majority of people that put these things in don't know how to use them. And they're not easy to use, and it's not that easy to read tracings. And there's a lot of variables involved. So we'll sort of make this a discussion. And part of the discussion means that you guys are actually going to have to say something. I know that's difficult for you sometimes. But even if you get things wrong, it really doesn't matter. We only execute like, what, 10% of the people that get wrong answers, right? So you got a 90% chance of making it out of here alive. That's pretty good odds.
That's pretty good.
Yeah, that's not bad. So who do you want to do hemodynamic monitoring on? And there's really just a simple answer to that.
Patients that are hemodynamically unstable.
Ha ha ha, okay. They're hemodynamically unstable and what's it all about? What is hemodynamic monitoring about?
Oxygen delivery.
Nah, sorry.
Pressures?
You know what, he goes. Okay. It's really not about oxygen delivery. And it's not about pressure, so you don't have very much left.
They're sick versus not sick.
No, it's about volume. It's all about volume. Why are you doing this? You want to figure out somebody's intravascular volume, right? And then you want to figure out their intravascular volume. You said volume?
I didn't say that.
Nobody said that?
Someone, well, we knew it was volume.
Okay, it is volume, right? And what you're doing is you're using pressures to infer volume. So right away, that's where you have errors coming into the equation, because there's not always a linear pressure-volume relationship. And like what we talked about with mechanical ventilators, with compliance equaling volume over pressure, the same thing happens within the circuitry of the heart. It's all about compliance, it's all about volume, and it's all about pressure, and whether or not you have a linear relationship between the two. And if you look at people that you're going to do hemodynamic monitoring in, not all those people are going to have a linear relationship between the compliance of their heart and the pressure changes that occur when you change volumes in those patients. You know, so if you take somebody with a real non-compliant heart and you put a little bit of volume in it, the pressure goes way up, and you're going to think their pressures are exceedingly high, but they're really not. It's more of a compliance problem. And if you have somebody with a dilated cardiomyopathy and you put a bunch of volume into them, because the heart is relatively compliant and baggy, pressure may not change very much at all. So right there's quite a bit of error. And the other thing that's going to happen is most of these people are going to be on mechanical ventilation, and they may be on PEEP. So how much PEEP do you subtract from the pressures? What is the effect of the positive intrathoracic pressure on the hemodynamic monitoring that you're doing? All these things have to be taken into consideration, and a lot of these things will change the way you think about the patient, and they may be right, they may be wrong. if you have somebody that's got a severely diminished LV because they're hypovolemic and you stick a swan in them, they may actually have a high number because the walls are coactive. And then you're diuresing a patient who's intravascularly volume depleted. So these are all the things you have to think about. So you want to put it into a hemodynamically unstable patient, which was part of the answer, whose volume status is unclear. And that's what you're doing when you're trying to do hemodynamic monitoring. And so what are the initial pitfalls of doing hemodynamic monitoring just from a practical standpoint? What do you have to do hemodynamic monitoring? So if you're going to do a Swan-Ganz catheter, it's invasive, right? If you're going to do a flow track, it's relatively non-invasive. And so if you're going to do a Swan-Ganz, you got to stick a line in, okay. So what are the things that are attendant, complications of a line?
Infection.
So infection, of course, and I'll tell you something. What happens is, and any of these guys that are a little bit more senior can attest to it, is these things go into people. You look at the numbers when they first go in, right? And then like nobody pays attention to the freaking thing after that. And then it sits there and then it gets infected or it causes some other type of problem. So if you're going to put it in, you should look at the numbers every day. And if the numbers are not indicating any change in management, then you take it out, basically. And you don't worry that so much about a flow track. I don't know if you guys know what a flow track is, but we'll talk about that. So infection, if you're putting in a subclavian pneumothorax, right? So pneumo. You can do valvular damage if you don't know what you're doing when you float these things, because they have balloons, and if you don't deflate the balloon when you're retracting it, you can blow a valve. If you have somebody that's got a left bundle branch block, you can get a temporary right bundle branch block, then you're putting it into someone and now they have complete heart block. I've seen that happen a little bit. Their heart rate goes down and your heart rate goes up, So heart block. And really, inaccurate information. And there's a lot of ways that can occur. And so, I don't know if you guys have ever seen these catheters. Basically what you do is you put an introducer in, then you float a catheter. It's got a little balloon on the end of it. It's got a distal port, it's got a medial port, it's got a proximal port. The distal port is where the balloon tip is. That's where you can get your mixed venous O2s out of if you wish to when you're looking at MVO2s. And the proximal port becomes important when you're looking at cardiac outputs, because you're going to inject certain things in the proximal port and look for temperature changes to determine cardiac output. The one thing you have to make sure is that when the nurse hooks up the PA catheter, they hook up the pressure monitor to the distal port. And I've seen cases where you're floating the Swan, you can't get a reading, and then you just look and it's just been hooked up incorrectly. So there's certain things that need to be taken into account. The patient needs to be in the right position. The manometry needs to be at the right level. And the catheter needs to be placed into the right lung zone as well. And so there's a lot of things that are variables within the act of floating the Swan and making sure that it's in proper position. Now, what you need to know about Swan-Ganz catheters, what you need to know about any element in medicine, is what's normal. Because if you don't know what's normal, you don't know what's abnormal. So this is like the dumbed down version of Swan-Ganz catheters, which is the one version that I can understand and remember. And I can tell you that if I have trouble remembering more complicated things concerning this, then I guarantee you that you probably will too. You know what I mean? So you really want to keep it to strict basic essentials and those certain hemodynamic profiles and those certain circumstances that indicate certain pathologic states. And if you know that, I guarantee you'll know that more than 90% of people that deal with these things. Because everybody gets caught in these C waves and X waves and Y waves and all that crap, and it's really not very important. So when you put this into somebody, you're going to get here's your ideal tracer. I know you're astounded by my artistry. Okay. And so this is your, you know, this is your CVP, this is your RA, this is your RV, and this is your pulmonary capillary wedge pressure. So for the sake of expediting this, I'll tell you, like, this is going to be a few centimeters of pressure. And your RA isn't much more. Like, you don't need to know numbers so much. Your RV is going to be ideally 24 over a few centimeters. I'm sorry, this is your PA. And then it's your wedge, but not the greatest drawing, but so this is your PA, and then this is your wedge. And your PA is going to be 24 over 8 with a mean of 14 is normal. And then your wedge is going to be somewhere between 8 to 12 in an ideal state. And that's your tracing. And so, so you need to know what's normal, and you need to know what's abnormal. So if you float a swan and somebody's got alveolar infiltrates and you're unsure of their, you know, volume status, and you see that this number is exceedingly high, they probably have LV failure, you know, and so on and so forth. So that's what you want to look at. And so you need to know what normal is. And you need to know, the other thing that people often do when they put in Swan-Gaines catheters is they get so excited as they're floating the catheter that they forget to write the numbers down. So what they do is they just want to know what the wedge is, and they forget to write down the RA and the RV and the PA and the pulmonary capillary wedge pressure. And you can't forget to do that, because when you construct your hemodynamic profiles and you figure out systemic vascular resistance, you need to know those numbers. Because again, you're dealing with circuitry. And so we'll talk a little bit about that soon. But that's really what you need to know. And the other thing that you need to understand is when you put this catheter into somebody, there's this thing called West zones. So these are lungs, believe it or not. It also looks like the 10 Commandments, I know that. And you have your zone 1, zone 2, and zone 3. So your zone 1, your alveolar pressure is greater than your arterial, is greater than your venous. Zone 2, your arterial is greater than alveolar, which is greater than venous. And not until you get to zone 3 does it become this relationship. So if your swan is in the wrong position, then you may be reading an alveolar pressure. You know, so if you don't get into zone 3, your pressure readings are erroneous. Now, when you talk about people that are in ICU or get a Swan-Gaines catheter placed, where does the catheter have to be? What position are most of those people in? They're supine, right? So the catheter has to be directed posteriorly, because when you go to different positions, your zones change. So if you're in a supine position, the anterior chest is zone 1, middle is zone 2, and posterior is zone 3. So when I was in training, one of the guys that trained me, he would get cross-table laterals as best as he could on every patient that would put a Swan-Gaines catheter in, to ensure that the catheter was directed posteriorly. But most people don't do that. Because you know what, most people don't know most of this stuff. They throw these catheters in, they get a pressure, they think they know what they're doing, they don't necessarily know what they're doing.
How do you physically direct it posterior, though?
You know what, it usually goes with the blood flow. And, you know, if you think about the lungs and you think about how the blood flows, where do you perfuse the most? You perfuse most at the bases when you're in a standing position. You perfuse mostly posteriorly when you're in a supine position. So it isn't difficult to quote-unquote direct it, but the blood flow sort of directs it. And you don't want to be out too far, you don't want to be too proximal. If you're out too far and you get to your wedge pressure, so you're in your PA and you get to your wedge, and then you wedge your balloon, you're going to see this happen. Because what you're doing is occluding that circulation, and you have to pull your catheter back a little bit. So, so these are the things. So you need to know those zones. Now the best book for you guys to read, if you're interested in this kind of stuff, and if you're interested in pulmonary physiology, is West's Basic Pulmonary Physiology. It's a real small red book. It's like 100 and something pages long. It's got big print and a lot of pictures, which is key to reading a book. And then there's West's Pathophysiology, which is really a redundancy of West's physiology. I was sort of disappointed when I read that. It was like reading the same book. So if you just get West's Pulmonary Physiology, it's an excellent book. And it not only covers this, it covers a variety of pulmonary issues. So now you want to get your hemodynamic profiles. And so what are you going to be looking at when you look at your hemodynamic profiles? What do you look at? From the numbers that you get.
You look at your, does it spit out cardiac output?
You look at cardiac output.
So your stroke volume.
SVR. Not so much. That's more with cardiac output, SVR, and your wedge pressure, right?
Yeah.
And that's what you're primarily interested in. And the reason you need to know these numbers when you put your swan in and need to record what you have is because what are the equations for SVR? And this is why you need to know circuitry. So the SVR, so I'll get it out of the way in a minute, equals the mean arterial pressure minus the right atrial pressure over cardiac output times the correction factor of 80, and it's like milligrams or something per dynes to the -5th, you know what I mean? I don't remember that part of it. I don't really care about that part of it. I remember about the absolute number. But if you haven't recorded your right atrial pressure, then you're going to have to go off your CVP. Now why is the SVR, why is that the equation for the SVR? Because you're dealing with a circuit. So what's the input to the circuit is the right atrium, right? What's the output? The aorta. It's output minus input divided by this cardiac output. So you're all circuitry. So if you know circuitry and you know physics, very basic physics, I liked physics. I thought physics was kind of cool. Then it makes sense. So what you're looking at is really resistance in a circuit, and you need to know the input to the circuit and the output to the circuit to figure that out. So your MAP is 2 times your diastolic plus 1 times your systolic divided by 3 minus your RA over your cardiac output times 8. Now you'll see varying numbers for normal SVR. So I use 800 to 1200.
Are you able to put your CVP instead of your RA?
You can, but you should really be recording your numbers when you put your swan in. I mean, it's not that hard. You should have somebody assigned when you're putting in the swan to record the numbers as you go through the different traces. And we'll talk about how you read those numbers. And you can have somebody punching out traces too, because it's different on ventilated versus non-ventilated patients. Just parenthetically, another nice thing to know, and you're not going to use it in these profiles, is your pulmonary vascular resistance. So your pulmonary vascular resistance equals your mean, pulmonary artery pressure, which would be the same thing, 2 times the diastolic plus 1 times the systolic divided by 3, minus your pulmonary capillary wedge pressure divided by cardiac output times 80. And that's usually, it's about a factor of 10. I don't care what numbers you use, if you see different numbers, but it's about a factor of 10. So your pulmonary vascular resistance should be about 1/10 of your SVR. And one of the reasons it's nice to calculate that out, if you think somebody's had a pulmonary embolism or has a primary pulmonary issue, what you'll see is that this PVR is high with respect to your systemic vascular resistance, and it may tip your thinking in a different direction. So once again, it's circuitry. Okay, it's output minus input over cardiac output. It's all circuits. It's really quite simple.
Yeah, I mean, yeah, I mean,
And so that you will construct these numbers. So now you've got your pressures in place, and now you get your hemodynamic profiles. And again, for the sake of argument, you really sort of ignore this PVR initially. And what you want to look at is your cardiac output, and if your cardiac output is low, and your SVR is high, and your pulmonary capillary wedge pressure is low, what is it?
So cardiac output's low.
SVR is high, pulmonary capillary wedge pressure is low.
Hypovolemic.
Good, hypovolemia. Okay, your cardiac output is normal to low, your SVR is low, your pulmonary capillary wedge pressure, or no, excuse me, I'm sorry. Your cardiac output is high, your SVR is low, and your pulmonary capillary wedge pressure is low or normal.
So it'd be like a distributive.
Distributive, exactly. So the classic is sepsis. However, there's like a laundry list, right? Thyroid toxicosis, cirrhosis, anything with AV malformations, anaphylactic shock, people with spinal shock, although you'll read different things about spinal shock. Sometimes it's low, sometimes it's high. People with burns stay like this for months. So one of the difficult things in evaluating burn patients for sepsis hemodynamically is that this is the way they will look hemodynamically, even if they're not septic. And so they're very difficult to figure out. And then it's, you know, low, high, and high cardiogenic shock. So these people are the people that you give fluid, right?
Mm-hmm.
These people are the people that you give fluid, but if it doesn't work, pressors. And these people, inotropes, and ultimately, if you can't fix them, an intra-aortic balloon pump. Okay? Or IABP. And that's what you do. Now, if you happen to see that your wedge is not that high and your PAs are high, then you think about a primary pulmonary process. And that's where you start to think about your pulmonary vascular resistance, and if they suddenly deteriorated, you have to give careful consideration to pulmonary embolism. They can also have, like, there's different entities that look like failure but have high PVRs, like pulmonary veno-occlusive disease. And then the other thing is that if you go through your tracings and somebody that's got maybe a history of cancer or had a recent cabbage or had something involving the pericardium and you get diastolic equalization of all the numbers, you worry about pericardial tamponade. And there's certain tracings that you can look at for constriction. It's called a square root sign. And they're like pretty simple to look at on tests, you know. You probably won't have this on your exams, but I have this on my exams, you know. So those are the basic hemodynamic profiles. The other thing is, where do you read your tracing? Okay, so you have somebody on a ventilator, you have somebody spontaneously breathing. You got to figure out where to read these tracings. So where you read these tracings essentially is, so a ventilator patient and spontaneously breathing. Now, when do you want to read your tracings?
Probably when they're spontaneously breathing.
doesn't matter.
Oh.
There's one answer for both. You want to be as close to atmospheric pressure as you possibly can be. And when is that?
Exhalation.
End expiration, right? Passive end expiration. However, if you're spontaneously breathing, to inflate, you're down, right? So here's your wedge tracing. And this is why you're inhaling. And then you exhale, and you come back to atmospheric pressure. So you're going to see your tracing vary up and down. So in a spontaneously breathing patient, you're going to want to read this when the tracing is up. In a ventilated patient, when they're inspiring, they're at positive pressure, right? And then as they exhale, they go back towards atmospheric. So in the ventilated patient, you want to read it right there. And then what I do is you take the 3 systolic numbers, the 3 diastolic numbers, figure out the means, average them together, and you get a really good number. I've done this looking at exams and everything, exam type questions, but that's how you read it. So you have to understand that. Now if you're somebody that's like bucking a ventilator, you're not going to be able to, they'll give you those questions too. Those tracings are uninterpretable because you'll never get them at the proper position. Or if you have somebody that's spontaneously breathing but like using all accessory muscles, you'll never get a valid reading. You can't. You'll never do it. And they'll actually give you those types of questions in critical care exams and everything. Uninterpretable due to the patient's respiratory pattern. Excuse me for 1 second.
Hello?